Now may we move into a very important topic for us, which is the Integrated Performance Report. Tim, if you would like to kick off.
So this is a paper really designed to seek from the board a view as to how best we can present some very complex information about the quality of delivery of NHS England as an organisation, and indeed also about the quality of delivery of the NHS as a system. So if you just turn to page 2, this report is trying to capture data that will help support the board's ability to hold the team to account across a whole range of, across a range of different sorts of measures. So we have in our business plan 11 core metrics is one, and probably the first standard reporting. We also, of course, are very interested in the degree to which we are delivering on our mandate obligations. We're very focused on the degree to which NHS performance is responding to our commissioning activity and so on. So to give you a sense of the variety of different indicators that we will want to consider in as a board. Just to make 2 other points before I pass on to other colleagues to talk about the substance of the report. We are limited by the degree to which we have data that actually actively and in real time or in useful frequency supports our ability to judge outcome and performance. So we've divided this report really into 2 parts. There is the first part, which is where we have data that usefully supports operational insight, and where there is data but it's frankly so historic that it's of no real use to the board currently in determining whether NHS England is having any impact. And we published that in section E. That historic data really is a baseline against which we can in future be held to account. But just to make that point, that we are limited by the amount of data. Clearly, as you know, and I've said in previous board meetings, we have a massive programme to hopefully quickly transform the infrastructure we have to enable much more data to flow. That obviously takes some time to deliver, but we've made some good progress. But for now, we have a limit on the data, and really the invitation to the board is to make comments on how best we can present this complexity of information, the way it's going to be most useful to board members. And if I just perhaps pass on to Barbara, just to pick up on some of the substantive points which start in paragraph 11.
Okay, thank you. If I can draw the board's attention particularly to section C, which is the NHS Performance and Finance Report. I'll pass on to Paul when we come on to the finance aspects of that. But you'll see in the narrative that we've picked out a number of areas which we thought we both had contemporaneous data and were critical in terms of the care of our patients to focus on for today. Clearly, if the board thinks that there are other areas we should focus on in the future, then we will do so. So if I can move straight from that to section C, straight from the narrative into section C of the Performance and Finance Report. And there are 2 distinct areas that I'd particularly like to draw out. In a little while I want to talk about 111 service, but first and foremost I'd like to talk about some of the key performance indicators that we use for the NHS. I think it is important to recall how these indicators came about. Patients have rights under the NHS Constitution and pledges to many aspects of care, but often specifically to timely access to their care. So, for example, patients have a right to be treated within 18 weeks of being referred to the hospital by their GP. They have a right, if they're suspected of having cancer, of being diagnosed and treated in a much shorter time frame than that. They have a right to be either discharged or admitted from the Accident and Emergency Department within 4 hours. And there's a range of other of similar targets, operational standards, quality markers. The patients have these rights, and we use a proxy measure to ensure that as a whole the NHS in England is delivering these standards to the vast majority of our patients. In certain instances, there are exceptions whereby from an individual patient's point of view it is better for their safety for them not necessarily to be admitted or discharged from A&E within 4 hours, but but it's a very small number of patients, and that's taken account of in the operational standards. So if we can turn to section C and start to look at some of the operational standards that we look at for the NHS to make sure that our patients are getting the right quality of care and not waiting too long. One of the most important and topical ones recently has been the waiting times in accident and emergency departments, which you will see from the graph did dip very significantly below what we consider to be an operationally acceptable standard, i.e. that 95% of patients were either admitted or discharged within that time frame. There is always a dip in the winter. It is easy to achieve these levels in the summer when there are fewer patients, and there's always a dip in the winter. But on this occasion, we had a more significant and a more prolonged dip. You'll see now from the blue line, or the dark blue line, to the left of the graph, that this operational standard is now being achieved and has been achieved for several weeks within the NHS. This has been due to a concerted effort from our commissioners, CCGs, and our providers in hospitals, supported by joint working between NHS England, the Trust Development Agency, Monitor, the Foundation Trust Network, and local government colleagues, in order to make sure that we have everything in place so that we have the right services for those patients, and the right services around the accident and emergency department, because often, of course, the issue is not what's going on in the A&E department, it's about how many patients are arriving at an A&E department, and sometimes how easy it is for the patients to be moved from the A&E department into the right ward in the hospital. And that often, of course, depends on the ability to discharge patients when they're ready for discharge. So a concerted effort, I think, has seen performance come back on track. We asked all health communities to come together using an urgent care board. So this was a group of people across the local health community, clinicians and managers, who would be able to look at the day-to-day issues that were actually blocking patients' swift movement through the A&E department, and to decide how the whole community could improve that service. And those urgent care boards not only have helped get everything back on track for the moment, but they're particularly looking at winter planning, because they need to be ready now for when we get the next cold snap. I know it's quite hard to think of on a day like this, but when we get the next cold snap and of the cold winter, and more patients and patients who are more ill are arriving in A&E. So that's the first one I wanted to draw attention to. I think it is worth ambulance performance. Again, patients' rights, depending on the urgency of their condition, to have an ambulance arrive swiftly to support them. And that performance now is excellent and as good as it has been for some considerable while. There are a few pages towards the end on 18 weeks referral to treatment, cancer weights, for which really performance has stayed stable and stayed good. So I didn't intend to talk about those significantly. And you perhaps notice on the back page that we are just looking at the activity. We track the activity very carefully. It's not really a performance measure, it's a matter of fact, but it helps us to plan services, both urgent services and elective care services. So if I can, rather than go into 111 straight away, which is perhaps slightly different, I might just pause there to see if there are any questions on the key performance indicators. Yes, that's all right, Chairman.
Let's do that. Nagy.
I think this, all of this data and the reporting is a really big step forward. The two things that I think I would be interested in if we can find a way to report them succinctly without making the reporting too voluminous, is to get more of a sense of the dispersion or the tail. So these statistics are all about the proportion that meet a certain standard, but what we don't see in it is how many miss it by a lot. And I don't know what the right way of presenting that or capturing it, but I think the problems that we've been, dealing with are about the tails, not about the majority. and we've got to find some way of reporting that. The second thing that would be helpful to get in the reporting is that some sense of regional, local variation. So is the performance consistent across the country, or is it very different between different parts of the country? And again, I don't know how you can do that succinctly without making the reporting voluminous, but it would be relevant in the context of our obligation on inequalities to be able to see something that has a regional flavour to it.
Certainly, I'm sure we can look next time as to how we could bring that information back. It is information that I sit down every week with TDA and monitor and look at, because so we are able to see what's happening initially in all the different hospitals in England, because often this is about acute hospitals, and there is very significant variation. I mean, a number of our hospitals do very easily meet this target week in, week out, and some struggle to meet it all the time. So we see that variation, and we are moving to be able to plot the degree of variation on a CCG basis, so that we can start to see which communities. So I think we can look to bring something like that to you. It's a question of how to bring it in a succinct way, and also I think the other thing that you were alluding to was in any particular instance, almost what's the tail look like. So yes, we see 90% of patients within 18 weeks, but actually how many patients are waiting significantly longer than that? How long is it when it's longer, I think you're asking, and also, is there a reason? Because again, with all of these, there are instances when things are in the patient's best interest. So we could look at a way to do that. But if I can assure the board that in the operations directors and the executive team, we do look at this information on a regular basis, and we do have it.
Kieran?
Can I just ask a question on A&E? I'm just looking at the graphs. I could convince myself that every year it's worse. So are we sure that the planning that's been done for next winter isn't trying to plan last winter for again, but actually we're assuming that pressure will be higher, and what are we actually doing to prepare?
Yes, it is. It has become more difficult year on year, and in general, the numbers of patients attending A&E and being admitted to our hospitals is rising. Although it is interesting that the very significant dip we saw in the last quarter of 2012-13, the total number of patients attending A&E was actually slightly down on the quarter of the preceding year in terms of admissions. So we've tried to look quite hard at the reasons for this in order to be prepared for next year, and why it was so off track. And I think one of the early things that everyone needs to be aware of is that the patients who wait longer than A&E, in A&E than 4 hours, are generally the poorly patients who are to be admitted. So I think there's a perception that out of all these patients that people wait when they've gone with a fair and not particularly serious disorder, and that's not the case. So even the small number that we see, it's quite a high percentage of the relatively small number of patients who are going to be admitted into hospital. It's relevant to look at it as against the total number of patients being admitted rather than simply the total number of patients that's turning up. So when we do miss that target by a significant margin, it's really genuinely ill patients who are potentially on trolleys or waiting for A&E. And actually what often happens is that the main reason is the ability to admit. It's not that A&E can't get through the tests and things they need to do. It sometimes is, but the ability to admit patients. So what we've been trying to look at, as well as obviously looking to make sure that particularly for frail, vulnerable and elderly people, we have more services available in the community, so improving GP services, improving out-of-hours services, and these are all the things the urgent care boards will be looking at, so that fewer ill patients or more patients who really aren't very well can be managed at home, which we think is what patients want and is best for them. looking at the systems and processes within the hospital, because we know that makes a huge difference. We know that sometimes patients aren't discharged because their tablets aren't ready or because they're waiting for a ward round. So looking at those processes, but particularly looking at the ability for discharge. And when we looked at, what were the causes of the dip in Q4, plainly, I mean, there were probably several causes. Increasing number of patients was not one of them. We had a very cold March, which we're fairly sure was a contributory factor. It was a transition period for the NHS. It was possible that in response to the Francis report, people changed the ways, their measure of how quickly they could discharge or whether they ought to admit somebody may have slightly altered and the perception of the targets. But another area, of course, was we all know that local authority funding has been difficult, and actually, one of the possibilities was that we're not able to discharge patients because the social care that they needed wasn't available to them. So we're looking at all of that in order to make all that the best we can possibly make it for next winter. That's the sort of day-to-day operational stuff, but of course the urgent care review that Bruce is leading it starts to look at the more radical transformation of the service.
Thank you. Perhaps now you'd like to turn to 111.
So turn to 111. Thank you. So if I can take everyone to the two slides on 111. I think what we mainly need to report here is the performance, because obviously that's what matters to our patients. And I think that if you look at the performance data, it's very encouraging indeed. We cannot pretend that some providers set off in this service in February and March when they didn't have the volumes of staff and the properly trained staff to deal with our patients appropriately, and we saw some very poor performance with patients waiting far too long and abandoning calls. However, I think you can see the top part of the graph actually shows how swiftly we are answering calls. The red line is our minimum performance, it's our quality standard, and you will see really that performance has improved dramatically since NHS England took on operational responsibility in April, and for the most part now we meet that major quality standard of answering nearly all the calls within 60 seconds, and the green line at the bottom shows whether patients abandon calls, and that's now down to the sort of abandonment rates that you would consider to be perfectly acceptable for a service of this nature. The other one I think which is really important is, I think people have been really worried about 111 in terms of handover to clinicians. The call handlers are lay call handlers, however they do work with a very specific algorithm which has been tried and tested over the years, and was created by the Royal Colleges and tested by them. But obviously on occasions the patient needs to speak to a clinician, and you'll see from the graph on the right, the pie chart on the right, that when this slide was created, 80% of calls were completed by call handlers without reference to a clinician. Of the 20% that were then handed on to a clinician, 3/4 of them were handed straight across. So this wasn't about patients having to be called back for the vast majority. And of the small percentage that were called back, half of them within 10 minutes. Now, we won't rest until everybody's called back well within 10 minutes. And I can report, actually, that we've now increased if we have the figures for the July the 14th, 90% rather than 80% were in a position where they were transferred straight away. And the vast majority of the remaining ones were called back within the 10 minutes. So I think performance has definitely improved and stabilised. That's not a reason for complacency. It's a very big and very important service, and one which we believe will be of enormous benefit to the public in the future. So we've got a full programme board in place, which is looking at making sure that we really have stabilised the system and got great delivery. We are looking at all the clinical and quality aspects and making sure that they're the best they can be for patients, and then looking to the future. So 3 parts to that programme, looking to the future to see what's the strategic direction for 111, what could we do to make it even better.
Well, thank you very much, Barbara. We know that the launch of 111 was not something that we would have wished, and we're coming back to that as an item later on the agenda when we look at how we will handle in the future major projects. This is one that, of course, we inherited at the time of its launch. But what I'm interested to know, I suppose, is what do you anticipate to be the increase in take-up of the use of 111? How are you projecting that forward?
We're already seeing a greater uptake of 111 than we first thought because of all the publicity. So when 111 is introduced in an area, it has what's called a soft launch initially. In other words, without a blaze of publicity, generally 111 takes two sorts of calls that would have come in previously. One is the 0845 number, which was less about urgent care and more about advice, and the other part is the GP out of hours. So in all areas, do the soft launch first, whereby if you ring either of those numbers, you would be just transferred through to 111, and the service runs for a while in that locality before that locality then starts to advertise to individuals. You can just dial 111, although of course, as I say, in a lot of places that's already happening. Actually, in 90% of the country, geographical coverage of the country, if you dial 111, you will get through to a local service because 111 is active, and if there isn't a 111 call centre in place, you will be automatically redirected to GP out of hours. So we've got 90% coverage already. The initial plan was that 111 would be rolled out everywhere. Initially, the plan was end of March. Many months ago, the Department of Health offered areas the opportunity to delay, and we did have a number of areas opted to delay until the autumn of this year. With the latest issues that have gone on, NHS Direct, who was one of the providers who really struggled, have informed us that they won't be able to provide the services in two areas that they were due to take up in the autumn, which is Cornwall and Essex. And we're now in the process of supporting CCGs, so I forgot to say we support CCGs, who are the commissioners of this service. We're supporting CCGs to seek alternative providers, and we have agreed on that basis that these two areas, the launch can be delayed even after the autumn. It's likely to be in the early part of 2014, simply because we think that ensuring that this service is absolutely safe before it's rolled out anywhere else is critical. And we do, in every area when there's either a new rollout or an increase of 111 breadth, then actually the programme board, which I chair, looks at that very specifically to make sure that it's ready to go.
Myra?
I just wanted to ask Barbara, if I may, Malcolm, that the second bullet, which you've been talking about, only 5% of callers compared to 70% under NHS Direct need to be called back to complete their assessment. Is this simply down to the quality of that algorithm? And is it that new, as it were, that because some of the criticism in the media has been about the number of lay call handlers rather than nurses or other professionals, really. So it's the satisfaction rates are very good. So that's an amazing difference, really. But is it just that algorithm, or is there something else that's making that so significant a difference?
I think, and I'm sorry, my eye was instantly drawn when you said the second bullet point to the principle, which has somehow crept in as the wrong, as spelt incorrectly. I do apologise. I think one of the reasons why things improve over weeks is the experience of the call handlers. So all the call handlers are trained, and they all use the same algorithm. And it's an algorithm that is used not only by 111. So it's a highly acclaimed algorithm for lay call handlers. And, we also need to remember that it isn't only 111 who doesn't have a clinician taking the calls. Ambulance services don't, and most GP surgeries initially it'll be a receptionist, so there's lots of areas. So I think that the improvement in the time has been as those call handlers have become more experienced. And that actually then starts to allow them to manage the calls much more swiftly and efficiently, and that's a better experience for patients, and obviously it means they can answer other calls. So we've seen in every site that's rolled out that as a few weeks have gone by, they've got much better. So we do have their very high satisfaction rates, but I think we need to be cautious about the satisfaction rates in that there's a bit of a time lag in their reporting, and actually the time when we were delivering the worst service to our patients was in March. And I think there still is a bit of time to just see. I suspect we will see a deterioration in satisfaction and then hopefully an improvement again. Did that answer the question?
I think so.
Thank you.
Okay, thanks very much. While we're still on this item, I'd like to invite Paul to talk about financial performance.
I'll keep this brief, Malcolm, but I think I just want to begin by paying tribute to the finance teams around the country, in the CCGs, in the CSU, and indeed in our own teams, who, to my mind, have pulled off or are well on their way to pulling off a pretty well impossible triple challenge. And I just think it would be worth our while noting that today. The first big challenge has been closing down the old world, and I have to say I was in some sense of anxiety, as it were, going into that process, because it's always complicated when there isn't another year to pick up the things that weren't quite done right in the final year. And it is true to say that that close-down process has gone exceptionally well. It's been actually one of the least problematic year-end close-downs that I've experienced in my time in the NHS, and I think that, as a first achievement, is a very big one. The second thing is, I've said before in the board meeting, this year's planning process is certainly the most difficult that I've personally been involved in, for two real reasons, one of which is the structural change itself, which has just given us all sorts of challenges of splitting out specialised from less specialised acute care and all those other challenges. And secondly, it is a really difficult year to plan for because of the inherent challenges of the economic circumstances and the other challenges. So it's good to be able to report that we have now got to a point in the planning process where we can close off that process and move into managing the year, and you might think it's about time too, but it is certainly really important that we can switch across from that. And then the third thing is, and we mustn't underestimate this, every one of the 212 organisations around the country, the commissioning organisations, has had to cope with a completely new accounting system, a completely new structure of accounts, a completely new set of reporting requirements, etc., whilst dealing with those first two things. So the fact that there is a page 10 at the back of the section C, which is the performance report, is frankly little short of a miracle. It's not a perfect page 10, I would say, in the sense that there's a variety of other information that we're going to bring from month 3 onwards, which will complement looking at whether we've spent more than we expected to or not. And I would say there's a handful of organisations who still, within the numbers you're looking at here, have got the odd little glitch they still need to sort out, which will come through in month 3. So I just thought it was worth putting that on record, because it's no mean feat that the teams have been able to achieve. Having said all of which, I would advise you to enjoy month 2 with a degree of caution, partly for the reason that I just talked about in terms of the novelty of the accounting processes. More importantly, because in month 2 for a commissioning organisation, you can virtually never tell very much, because you've only got really 1 month of solid data and the rest is kind of estimation. And whenever you've got a large quantity of estimation, it's dangerous to extrapolate from trends that you can see coming through. So the fact that we are apparently, according to this, slightly underspent cumulative to month 2, and I hope to get a consistent pattern that anything you see which hasn't got red or a bracket around it is good news. So the fact that we are marginally underspent in month 2 and that we aren't showing significant variances in the forecast outturn is good, that it doesn't have any indicators of negativity around it, but it's not a reason to think that we're through the woods and out the other side. Far from it. I anticipate being able to bring to you much more interesting financial reports in future months for all sorts of doubtless good and bad reasons. But I'd advise you to, as I say, just enjoy these numbers with a degree of caution.
Thank you. Nagi.
One comment and one question. The comment is really that going forward, I think it would be helpful to be able to see the costs that relate to NHS England that are the direct costs that we manage, so the 6,500 people and establishment, etc., because they get drowned out by these very large numbers, and that's really the thing that we're responsible for directly managing, and I think it would be helpful to see that broken out. And the other question was just to amplify on your point about estimates. The places where they're quite big numbers and the plan and actual is identical, is that because they're estimates or they really are identical?
It's in a combination. It depends which column you're looking at. So let me deal with the second question first, and I'll come back to the first. So in terms of the forecast outturn, it is absolutely normal that at this stage of the year, unless some calamity has taken place, you would see those in line. In the year to date, it is essentially, remember what I said, so the first month they've got hard data to go with. These are 2-month numbers. So typically there will be an estimation for the second month which puts it there, and if there isn't a significant trend one way or t'other, it wouldn't at all surprise me if most of them were in line with plan. And if it gives you any comfort, it may not do. I looked back at the month 2 reporting from the old system last year, and it was a very, very consistent pattern with what you're seeing here. There was only one organisation last year which was showing any significant variance at all at month 2 from its plan. So it's a fairly typical profile. If I go back to your first question, in the full set that I talked about that we've got for month 3, there are, I can't remember how many, 5 or 6 charts on finance, one of which is a very specific directorate by directorate, programme by programme look at the internal costs. It comes into the section which I think we call organisational health, section D, that comes after this. We haven't got that fine information available for month 2 for all the reasons I talked about. We will have that for month 3.
And in aggregate, well, you don't have it split by area, but in aggregate, are we more or less on track for the own establishment costs?
At month 2, with all the caveats that I gave earlier on, but yes.
Yes.
Yeah, a couple of points on the financial stuff. I would echo Paul's comment that the staff have to be commended to getting where they got to, but also Paul's warning that there may be some things yet to come, particularly in terms of the year-end cutover and transition. But the wider point, Tim, I mean, this is tremendous progress. And I think once it's online and we can look at it on a layered basis and we can start doing some of this exception reporting, this dispersion tracking from the mean, great. But the point that is also important, I think, for the board is that we have a mechanism whereby we are very clear that the information is being assured, and that therefore what we're looking at is data that is accurate, complete, and has had a systems-based assurance over it, because this is going to become vital decision-making information. So I would look to the internal audit function having an oversight, having a look at the generation of this data from source to board in a number of areas. And I'll report back. I think we must report back on that later in the year when that work's done.
Yeah, I think we can sum up by saying this is a major step forward, Tim, and we're appreciative. We take on board your initial comment that some of the data is very useful because it's timely and it's ours, and some of it isn't very useful at all, but gives us some sort of potentially unreliable historical background. But as the year goes by and as the quality of the data and the direct applicability of the data improves, so we'll have, I think, high quality reporting, with all of Ed's reservations about ensuring that the data itself quality is assured. I think we also, taking Paul's point, sometimes it's easy for the non-execs simply to forget how complex has been the process of underlying change, and how much work has gone into this across the whole of the organisation. And I have our attention drawn to the fact that everybody's working with a completely new accounting system and new accounting standards, I think, is quite a remarkable change. But for the first time, we have actually got the ability to capture all the information for the system as a whole, and I think that's a major step forward. It'll take a while, I think, for the system to develop. Take a while for us as a board to understand what is the best information that we need to provide us with the assurance on a meeting-by-meeting basis. And we'll work with you over time to bring ourselves to that position. Victor is looking at me inquiringly. Victor.
The only point I was going to make was that parity of esteem between mental and physical health is quite a different request of NHS England, and there might be some other things that I couldn't quite see. I mean, as the data and information develops, I just wanted to flag up that it's something that we need to measure, because there's no indication. I don't know how we get there, to be honest. I mean, on the question of understanding the complexity, the sheer weight is an indication of how much work's gone into it generally, but on the mental health, the palliative esteem stuff, I'm just not clear.
Well, and more broadly on the whole inequalities piece, which is critical to our success. So there's a load of. I mean, I would like just to echo Paul's point that this reflects incredible work by a group of people right across the organisation, led by Richard Murray, our unbelievably great chief analyst. And they have, you know, just the act of doing this has raised all sorts of really vital issues around how we do hold ourselves operationally to account for, and actually the very complex question of how we measure inequalities is one of the core questions. So I'm really hoping that as quickly as possible, but certainly over the next few months, we'll be coming back with a much enhanced view of both the methodology for measuring some of these things and subsequently the data to support the measures. But it is work in progress. But
Thank you.
Are we not on the way to having a globally unique system of reporting and of data? I don't know of any other system in the world that could produce this level of data, not just produce it, but have it in the public domain.
yeah.
Malcolm, just one more point which reinforces that, and it doesn't come through in the data, is this is national data, and because we don't have volumes, we have percentages. We don't actually see the scale that we're actually reporting against. It might be quite helpful from time to time to build the scale of this in terms of the absolute numbers of people that are going through A&E and other things. You've got it, but it's...
Yeah, and I think the online point that you made earlier is really important. I think probably what we need to do, and I'll talk to Richard and Grant Lewis, who's also been very involved, as to how we can particularly bring non-executive members of the board up to speed with what is already available online, which I think would help answer some of those questions.
Okay, thank you. Bill?
Sorry, Malcolm, just one point in response to Victor's question, which I think is a really good one, is just to give you the reassurance that on some of those more difficult to measure areas like palliative esteem for mental health, we're not just waiting until we can define a measure. There's Geraldine Strathley's and great clinical leadership work to try and define that programme, working with different patient groups to start saying, well, what would great look like? So we can put some actions in place that we can measure as we develop the outcome measures at the same time.
Good. Well, Tim, Barbara and Paul, thank you very much for that item. None of this ambition comes without risks.